Good evening, everybody, and welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Dr. Saurabh Agarwal from London, United Kingdom. Dr. Agarwal is an orthopedic surgeon based in London, UK, specializing in upper limb surgery and trauma. He moved to London in 2004, where he completed his orthopedic surgical training. He passed his FRC's ortho exam in 2012, followed by the EBOT in 2013. He's triple fellowship trained, shoulder, elbow, hands, and trauma, and has undertaken it in King's College Hospital, London. He's active in research and has done presentations at national levels. Presently, he's working as upper limb orthopedic surgeon at the Royal University Hospitals in London, United Kingdom. Lectured several times on our channel and has reached to a huge audience all over the world. And today, it's my great honor to bring back Dr. Saurabh Agarwal for this wonderful live program. Over to you, Saurabh.
Thank you, Hitesh, for your very kind invitation and for a very generous introduction. And hello to everybody. I'm Saurabh. I'm a consultant upper limb and a trauma surgeon. I'm based at Peru. We are part of King's College Trust. And our topic today is arthroscopic anatomy of the shoulder. So we want to talk about glenohumeral joint and subacromial space, bursa and rotator cuff. So these are the topics that we're going to touch base today. So we'll start with setup, patient positioning, surface anatomy, bony landmarks, and then finally how sort of with the arthroscopy. So I've got some videos to show how it looks, what it looks like in a glenohumeral joint and in a subacromial space. Then after we've done a tour of the shoulder, we'll look at the normal variants to the labrum. And finally, some tips and tricks to get a good visualization inside the shoulder while doing arthroscopy, and then triangulation tips and tricks. So starting with setup, there's two ways we can do shoulder arthroscopy. So I would do what I've shown on the left side of the screen, a beach chair position. So this is not me, but this is where the surgeon stands. That's the monitor. There's the assistant holding the arm for you. You can always have an arm support if you want to. The advantage of assistant holding arm is you can move the arm as you need it while doing arthroscopy. Again, beach chair advantage is familiarity, because we do arthroplasty work and most of the trauma work in beach chair position. So with shoulder arthroscopy in a beach chair, it's sort of easy. Second, it's easy to convert it to an open procedure should the need arise. Third, there's almost no chance of damaging the nerve. Of course, the flip side is the circulation to the brain, because we as shoulder surgeons always ask our anesthetist for a hypertensive anesthesia, which means the perfusion pressure may be less to the brain and there can be cerebrovascular ischemia and events. Now, if you come to the lateral position, so advantage will be there's hardly any problems with the cerebrovascular events because patient is supine. But the disadvantage is we're not that familiar because we give a traction. So there can be traction neuropraxia. Anterior portals can be difficult. If you need to convert it to an open procedure, it can be difficult. But again, advantage is your sort of no cerebrovascular events, almost none. And the other advantage is because you're giving a traction, joint opens up, both your glenohumeral joint and your subacromial space. So both have their pluses and minuses. Based on your training and your practice, you can pick either or. There's no right or wrong in terms of the patient positioning. So then let's see the bony landmarks and your portals. Now it's a busy slide, but I'm going to just try and make it as simple as I can. So in terms of bony landmarks, your C is your coracoid, B is clavicle. So this is obviously a beach chair position. A is your acromion and D is spine or scapula. And this line there marks your acromioclavicular joint. Then in terms of portals, so your first portal is what I've said, number 1 here. So that's the portal that's your viewing portal. That's where the arthroscope goes in. Then if you have to do any work on the anterior shoulder, Then your second portal is what I've said here as number 2. So through this portal, and we're going to see them in the videos also, you can do a biceps stenotomy, you can assess your labrum, both your anterior and superior labrum. So this is a very important portal, both for debridements and for repair. Then your third portal is what I've said here, number 3. So this is where your bony shaver goes in for your subacromial decompression. And then let's try and simplify the other portals. So for your rotator cuff repair work, you will need this portal, portal number 5. This is where your anchor will go in the footprint of your supraspinatus. Then you can use all these portals, portal number 11, portal number 4, all these posterolateral portals for your suture management, for your rotator cuff work. Now, you're looking at this portal number 10. This is a portal of Wilmington described by him. This is for your slap repair. So you can access your superior glenoid and your superior labrum through this portal. And then your portal number 7 and 8, these are for your posterior labral repair. Because as you can see, they're quite low down. So they're for posterior labrum. Then if you come in the front, this number 6. Now, you can have any number of portals. You can have your own portals as you feel like. But any portal in the front will be for anterior labrum repair, for superior labrum repair, for debridements, for biceps stenotomy, basic, and your subscap repair. You can have portals in different positions also as it suits you. And finally, this portal number 9 is your Nevasia portal. So as you can see, if I put a needle and then my instruments through this portal, I'm right on superior glenoid. So again, for my slap tears, superior labral tears, for the repair work, I use this portal. And then, again, this is a busy slide, but for those of you who do arthroscopy work regularly, I put a slide from this review article where I've said which portals to be used for what shoulder work. And this is again a very good review article which I was reading to sort of make this presentation by Mr. Brophy. This was published in American Academy 2013. It's one paper I'll recommend to all of you. Now, this is an important slide. So arthroscopy work, as I was saying, nerves are very important. In a beach chair position, a nerve injury should not happen if you're aware of the anatomy of your nerves. So there are 2 nerves. If I take you to the right side, let's start with the axillary nerve first. So we know it comes from posterior cord and then runs on the lower border of subscap, then dips and goes posterior, accompanied by your posterior circumflex. And then if I take you to the posterior shoulder specimen, so it's coming out of the quadrangular space with posterior circumflex. That's where axillary nerve will give various branches. So it's going to give a branch to skin, it's going to give articular branches, it's going to divide into anterior and posterior branch, which will be running on the anterior and posterior surface of deltoid, supplying deltoid, teres minor, and your regimental badge area. So now your posterior portal, so this muscle there is teres minor. You can see teres minor, that's teres minor. So nerve is between teres minor and teres major. That's your quadrangular space. Your posterior portal is between infraspinatus and teres minor. Somewhere there where my arrow is. So if your posterior portal is low, very low by mistake, then there's a chance we can damage axillary nerve. So if you have to err with your posterior portal, if you're not sure, if anything, err slightly superior, don't go to inferior. So that's one thing to remember with your portal and axillary nerve anatomy. Then as the nerve moves lateral, we all know it's roughly 5 centimeters from the tip of acromion, but the range is from 3.75 to let's say 6 or 7 centimeters. So again, if your lateral portal, because we saw there are so many lateral portals which you can use and utilize for your cuff repair work. So if your lateral portal is too low, you can damage the nerve. And similarly in the front, with your front portals, again, if they're too low, if they're anteroinferior, nerve is in danger. So important to know the anatomy and your sort of where to put your portals. Then suprascapular nerve is given off by the upper trunk Then it goes into this suprascapular notch. Water flows above the bridge, so artery is above the foramen. And then if I take you to again to the posterior sort of cut section, nerve then comes in the spinoglenoid notch and supplies. So supra before, once it crosses the notch, then it supplies the infraspinatus. So you can see as it goes through the foramen, just as soon as it passes, it's supplying supraspinatus. Then it comes through the notch, spinoglenoid notch there, and then supplies your infraspinatus. So again, if your posterior portal is too medial, then this nerve can be in danger, but it has to be really medial for us to cause it. Other relevance to the anatomy is if your anesthetist is not keen on a interscalene block or a supraclavicular block, then you can block the supraspinatus nerve yourself. So now that we've seen the sort of the landmarks, the bony landmarks and these portals and the nerves in danger, let's have a look at the glenohumeral joint through the arthroscope. So I think I did the scope just last week actually. So this is gleno. I'm going to start and stop a lot of times. So you can see that's your humeral head, that's glenoid. You can ask your assistant to externally rotate the arm to see the whole humeral head to assess the cartilage. And then you also assess your anterior labrum at the same time, the whole entirety from superior to inferior. And then so you can see, oh, sorry, I think it's starting again. So you can see that's the whole labrum, which I'm pointing now. This was a normal foramen, which is a normal variant, which we'll discuss in the coming slides. But let's carry on. So next step is to go to the superior labrum, and you can see there's a lot of fraying there. This lady was young actually, in her late 50s. And then as you see labrum, superior labrum will take you to long head of biceps. This is where biceps is attached to the superior labrum. And that's where you will get your slap tears. Superior labrum, anterior, posterior. And then finally, see, you've gone to your rotator interval now. So that's your biceps, that's your subscap. You can see a lot of inflammation in the rotator interval. It's all red and angry looking. So if you carry on with this, now you need to assess your subscap in a bit more detail. So you can see I've gone, oops, sorry. So now we're going to go down and look at the subscap in a bit more detail. And you can see these are longitudinal splits. So this is your lesser tuberosity. That's the footprint of lesser tuberosity where subscap attaches. So attachment is okay, but there are longitudinal tears. So all you need to do here is debride them. But it's important to assess that and take pictures for medical legal purposes. So you can see the tear in subscap. Then we're going to come back out. And the rotator interval inflammation needs to be debrided. And then if you follow your biceps, and you can see that's biceps, that is going into the bicipital groove. And the structure next to it is the anterior edge of supraspinatus. So we'll see that in a bit more detail. So biceps was normal, not inflamed. And you can already, I'm sorry, I'm not sure why it does that. Sorry about that, guys. So I'm not going to stop this video. I'll just keep saying. So that's our biceps. That's the anterior edge where we were. And then we're going to see in a minute that anterior edge, you can see it's all frayed. So we know there's an anterior edge tear. Now, when we go into the subacromial space, we'll see the tear in a bit more proper way. But you can see this all fraying. So you know something is not right there. And if it's a very small tear, at this stage, you can pass a needle to come out of this area. And then once you've seen it, you will go and you can see rest of the supraspinatus is all pristine compared to the anterior edge. So we know it's an anterior edge, maybe a centimeter tear. Rest of the supra looks okay. So you need to go further postero-inferior. there. So that's your infraspinatus. Looks very pristine. And you go all the way at the inferior humeral head back into the glenohumeral joint. There. So basically, in a glenohumeral joint, you start with humeral head, then glenoid, then anterior labrum, then superior labrum, then root of biceps. Then you assess your rotator interval inflammation, then subscap. Then you come back to biceps, follow the biceps to the anterior edge of supraspinatus, because 90% tears will happen in the anterior edge, 1 or 2 centimeter tears, mild or medium tears. Then you need to see the whole supra and infra in entirety, come back out, see the inferior axillary pouch, back into the glenohumeral joint. So there were 2 findings here. We found a subscap longitudinal tear and a supraspinatus anterior edge tear. However, there was a bit of superior labrum fraying also, which was debrided. So let's still carry on with the glenohumeral joint. So once I've done this much with my arthroscope, as we were talking about the anterior portal, so your second thing to do is establish your anterior portal, because in this case, I found some superior labral fraying, so I needed to deal with that. Now, these are not my pictures, but just for clarity, I've included. So you can see humeral head, subscap, this will be biceps. So this is your rotator interval. So you put a needle once you are happy. Depending on what you want to do, you can put 1 cannula, you can put a probe, you can put 2 cannulas. Like for my anterior labral repairs and for my slap repairs, I will either use a Wilmington portal or I'll use even 2 cannulas from the front or even from Nevasia portal, depending on how sort of patient body habitus is and how big is the tear. And sometimes you'll have a pan labral tear. You will have anterior labrum, superior labrum going into posterior labrum. So depending on what work you are doing, you will utilize all these portals. Other thing for you to remember is see this middle glenohumeral ligament as it goes in front of your subscap. This is important in our Buford complex, which we'll discuss in the coming slides. So let's see another video of the same patient. And here you will see as I'm debriding my so what I've done is I've already debrided my superior labrum. So you will see the difference. It was frayed and now it's all looking better. And then I'm probing with a probe, or because I've done many, so I'm just probing with this. And you can also see this needle like here. So once I know my needle was in the right place, I have put my diathermy pad your anterior portal, whether it's 1 portal or 2 portal. And this is me probing my labrum. And you will see that there is a foramen there. It's not a tear, it's a foramen. So that's superior labrum. I probed it. This is glenoid cartilage. That's bone. That's the border of superior glenoid. You can see labrum is stable after debridement. And this was the foramen there. So it's a normal variant. It's not a tear. Why do we say it's not a tear? Because if you see the anterior glenoid cartilage, that was healthy. So this is how I know it's not a tear, it's a variant. So then if I take you to the next slide, again, this slide I've taken from Google, again, for the clarity. So this is what I was saying, superior glenoid, but when you probe it, see when there's a tear, there's a slap tear, how far back it goes, and you can lift it up. Unlike what we found in our last slide in the video. So you can see biceps. So you can see biceps, superior labrum, that's a tear, slap, superior labrum, anterior, posterior. So this will be anterior, this is going to be posterior. So to repair this, you can use your Nevasia portal, Wilmington portals, anterior portals, depending on how big the tear is. And is it extending further posteriorly, or is it coming down anterior, or is it an isolated slap tear? So slap tears, they extend normally from 10 to 2 o'clock, as you can see here. On the other hand, Bankart tears, which comes with your anterior shoulder dislocation, they extend from 3 to 6 o'clock. So just remember that. And your variants, your anterosuperior labral variants, they extend from 11 o'clock to 3 o'clock. So you need to remember the different sort of positions of variants and for tears. So once we've done the glenohumeral joint, now we need to see the subacromial space. So remember our first portal, posterior portal, that's a viewing portal. And then we need to go laterally with our shavers. So once we've established the portals, let's see. So I've established the portal. This is my subacromial space. So with your soft tissue shavers, followed by your diathermy, you need to shave off all the bursa and all the tissues, inflamed tissues. And then, so I want to show you, okay, there. Can you see this needle? Now, remember we found it was a very small anterior edge tear. So at that stage, I put a small needle into the glenohumeral joint. So this needle, I knew, was right over my cuff tear. So sometimes with a small cuff tear, when you're in a subacromial space, this needle will straight away take you to the tear and save you a lot of time and hassle. So I know again that my tear will be somewhere next to the needle, and you will see in a minute how I'm going to find my tear with my diathermy. Like I'll just probe it. So see, once I've debrided all the bursa and the tissues, so that's my tear. Oh, sorry. So you can see with my diathermy, I've gone in under the cuff tear. And if you keep watching it, I'll further tent it up. See, so that's your tear. So I know two things straight away. One, obviously it's only a small tear, but I can fully mobilize it. And two, there's a tear. Now, other thing to appreciate here is I've now turned the light source. So I'm looking at a chromium, and see with your diathermy, you need to take all the periosteum away, and you'll see in a minute how a chromium will reveal itself. Small tip here, a chromium is more anterior than what we imagine. So when with your shavers, with your bony shavers, with your diathermy, you need to go more anterior than what you think is the acromion. So you can see a chromium, this bone is starting to reveal itself. You can see it's like a gentle curved acromion. We can see in a bit more detail in this slide. So again, with the diathermy, I'm taking off all the periosteum. Another little tip here, with the diathermy, if you go too anterior, now once you're taking off acromion, and I'm on the inferior border of the acromion, deltoid is just there. So just be aware of deltoid, and you don't want to dehisce deltoid, and you don't want to cause any bleeding from deltoid. So that is important. So this is me with the diathermy, taking off all the periosteum. I just wanted to show you the deltoid. If you see all these red bits, that's deltoid. You don't want to go there. Again, I have turned my light source. So you saw acromion, and now you can see the needle, and this is the cuff tear, roughly a centimeter cuff tear. So in your subacromial space, there are three things. One is acromion for your SAD. Second is your cuff for your cuff repair. And third thing is to get rid of bursa. Because one, it is inflamed, it'll give pain. Two, unless you get rid of it and all the adhesions in the lateral pocket, in the posterior pocket, in the anterior pocket, patient will struggle with physiotherapy. So post-op rehabilitation will not be good. And so you want to take away all the adhesions to have good post-op rehabilitation and good range of function. So this is what we did. This is again a slide from Google. So you can see some curved acromion. Sometimes you can have spur, but see how narrow the space is. So this patient will have mechanical impingement to supraspinatus on overhead abduction. And this is me doing subacromial decompression basically. So again, this is your third portal, number 3 portal. You bring your bony shavers and you shave off acromion. Now a little tip here is, if I can, yeah. Because this was a very sort of a gentle curved acromion, so I have just generally shaved it because I was making videos as well. Otherwise, a tip is you start on the lateral edge, anterolateral edge. You calculate how much acromion you want to take off, depending on the size of acromion. You make that much divot here, and then, so once you know you made a divot of 8 millimeters, you just need to extend that through the entirety. So that way you are in control of how much acromion you are shaving. So this is just me shaving basically. And in between, of course, you put your diathermy, you take all this periosteum and bursa away, and you complete your SAD. Then let's come to the normal variants. It's very important to know which is a tone labrum, which is a sort of a normal variant. So 85% patients will have an intact labrum, your anterior superior labrum. But in roughly 2.5%, what they found was on the superior labrum, there can be a sublabral recess. So you have to make sure you don't want to confuse it with a slap tear, because if you repair this, then patient will have markedly reduced external rotation and even pain. So one way to differentiate will be the cartilage. If on the superior glenoid, cartilage looks pristine, if there's no fraying, then you know it's a normal variant. Similarly, around 7.5% will have a sublabral foramen, which is what we had in our case, because your cartilage on the anterior glenoid was all pristine. Finally, the Buford complex, which again you will see in 4%. But if I take you to the next slide, I can explain Buford complex a lot better. So now, remember this slide which I showed you, this picture which I showed you in previous slide. So that's your normal labrum. That's the middle glenohumeral ligament, which is like a little curtain in front of subscap. Now, compare this picture to this picture. So if this labrum was to be absent, the top sort of 30%, and this ligament was to become very thick, so which is what this picture shows. So absent labrum, top 30%, and this labrum this middle glenohumeral ligament has become very thick, like a cord, like a thick cord, as you can see here. Now, to an untrained eye, this may look like an anterior labrum tear, like a superior anterior labrum tear. And if you were then to put anchors and repair this thick cord like middle glenohumeral ligament, thinking it was an anterior labrum, you can imagine how tight this shoulder will become and painful the shoulder will become, and the loss of movements that accompanies it. So how will you know this is a variant and not a tone labrum? Look at the glenoid. It's all pristine. There's no damage. There's no fraying. So you know this is a variant and it's not a tear. And we saw sublabral foramen and the sublabral recess on the top. So these are the normal variants. They all extend from 11 to 3 o'clock. So now visualization. Now visualization is very important, and it is dependent on your team, on your equipment, and on your anesthesia. This is one area where you can sort of, it's not just surgeon dependent, you're dependent on your whole team. So equipment has to be good. Fluid pressure. Now, if you increase a lot of fluid pressure, yes, you can stop the bleeding from capillaries, but increased fluid pressure means all the fluid will extravasate into your soft tissues. It will stretch your capsule, and patient will wake up with a very swollen and stretched capsule, i.e. pain, which means he can't do his rehabilitation and exercises properly. So you can't increase the fluid pressure beyond a certain measure, which then brings us to the next point, that you are very then dependent on anesthesia. Shoulder arthroscopy is more about hypotensive anesthesia. After a stage, anybody can do arthroscopy work, but your anesthetist should be shoulder trained, basically. So if you get a good hypotensive anesthesia, your capillaries don't bleed, it doesn't obstruct your view, and you can keep your fluid pressure low and operate. Finally, fluid turbulence. So don't make create a lot of open portals. And if you have, for some reason, then stitch them, because fluid keeps coming out of them when you're operating and creates a lot of turbulence, which makes your visualization difficult. And then again, make sure suction tubes in your equipment they're not on an excessive suction. Triangulation. This takes time. I'm sure you've all done knee scopes. So basically, that's your arthroscope. Whichever instrument you want to put in, whether it's a probe or a shaver or a diathermy, you need to aim it just at the tip or slightly anterior. And if you're struggling, easy thing, especially in difficult scopes sometimes, put your probe or your shaver or your diathermy, like touch to the sheet, that's easy. And then slide it anterior, just in front of the light source. Moment you start seeing your shaver, it's very easy to do SAD. So this is a very important tip. Touch your sheath and slide anterior, especially when you just started to do shoulder scopes. So for example, here, that's coracoid. So that is anterior. Your viewing portal is posterior. Arthroscopes come from behind. And as your shaver goes in, you can touch the arthroscopy sheath, slide it just in the front, and you will start seeing your acromion. And then you can shave off the excess bit, which is what this slide says. So basically, arthroscopy is about knowledge of your nerves, your bony landmarks. You need to know where to put your portals and which portals to use for which shoulder work, to understand what to see inside. Visualization equals hypotensive anesthesia and managing fluid pressures, and then triangulation. So once you can do that, as I just showed you, the cuff repair and the SAD then falls in place. It's not that difficult. And in my next lecture, we're going to talk about arthroscopic rotator cuff repair. So I thank you for your kind attention. Happy to answer any questions. Thank you.
Thank you, Saurabh, for yet another brilliant presentation. Couple of questions, Saurabh. What is the position that you use normally? Is it beach chair or lateral? And what is the rationale?
Yeah, so you use a beach chair position. I'll take you to setup. So there's no right or wrong. One, whatever you are trained in. Second, like as a shoulder surgeon, I'll do all my arthroplasty in a beach chair position. I'll do proximal humerus fixations in a beach chair positions. So you are already familiar with that approach. So for me, it is sort of taking it to the next level with arthroscopy. I already know the position and the anatomy. So it's the familiarity. Second rationale is, if for some reason I have to convert my arthroscopic procedure into an open procedure. For example, sometimes ACG excisions can be difficult, or I feel I've not done adequate, or shoulder has swollen up a lot. Or in those cases, if I do an open ACG excision, then in a beach chair is much easier. Third, nerve damage is almost not possible if you know your anatomy and your arthroscopic portals. You can, there's hardly any literature which suggests nerve damage in a beach chair. The problem with beach chair is your hypotensive anesthesia and your perfusion pressure to brain is compromised, and then that can lead to cerebrovascular events unless your anesthetist is shoulder trained and very confident.
Okay, so that is something that you need to really take care of, right? Cerebral hypoperfusion.
Correct, correct. So absolutely. So this is where not every anesthetist is comfortable giving anesthesia in shoulders. And this is where your lateral decubitus position comes, because patient is supine. So circulation is never an issue. So your happiest person in your theater is your anesthetist. But on the other hand, because your arm is on a traction, so traction neuropraxia can happen in lateral decubitus. Second is familiarity, because most of your work is in beach chair. Third is your anterior portals are difficult. So there's no right or wrong. Idea is whatever you are trained in, you should use that position, and you should idea is to do a good job and a quick job.
And how much is the inclination or the reclination that you require? Like the angulation, 70 degrees, 60 degrees?
Around, yeah, 60 to 70 degrees, basically.
Okay. And is there any study that says that, okay, 50, an angulation that is significantly steeper can increase the risk of cerebral hypoperfusion? So that we can tell the anesthetist, okay, don't go beyond, I mean, don't flex it more than 70 or 80.
Yeah, I think, well, not sort of, I've never thought it like that, but I know beyond 45, 50 degrees, you are decreasing a bit of perfusion. Up to 45, anesthetists are still happy. So for arthroplasty work, that's what we do.
Thank you, Saurabh, for that. And Saurabh, have you encountered a condition called as a spinoglenoid notch cyst, where there is an isolated infraspinatus atrophy, and because there is a cyst in the spinoglenoid notch, and one of the treatments is a suprascapular nerve decompression, right? Cyst excision. So how do we approach? Is it through the Neviaza portal?
Okay, so first of all, yes, cyst do happens. Clinically, you will see supra has a good bulk, infra is gone. So unless you are aware of this pathology, you will think, well, hang on, suprascapular nerve equals supra and infra. How come there's an isolated infra nerve muscle, infraspinatus muscle bulk loss? So it does happen. If it happens, you get an MRI, see the axial cuts, you'll see a ganglion in the cyst putting pressure on the nerve. And the answer is yes, you have to actually decompress the ganglion, and then the muscle comes back. Personally, I've not done one. Like I've seen 2 or 3 cases in the last 7 years. So even if I'll see one now, I'll send it to a pure shoulder surgeon. Like I do hands and elbows and shoulders. So I wouldn't do it in UK myself.
Okay, thank you for that. Thank you for being very honest about it. And superior capsular reconstruction is again something that's catching up, and you need to place the anchors right there, right on the edge of the glenoid. So I think those are the ones again that you can approach via Nevier portal, right?
Totally true. And again, superior capsular reconstruction, arthroscopic is like very difficult. It's like doing a latigial arthroscopic. Even in UK, unless you are a pure shoulder arthroscopist, not many people do them. Jury is still out between graft jacket and a SCR. We do graft jacket in our practice at King's College. We're not doing SCR. But yes, Nevier portal is because you are approaching the superior glenoid. That's where you are attaching your sort of SCR. So Nevier portal comes in very handy.
Thank you, Saurabh. I think that's all the questions that we have for this session. Again, yet another fantastic lecture from your side, and I'm sure this lecture is going to benefit a lot of people all over the world. Thank you so much, Saurabh, for joining in.
Thank you, Hitesh, for your kind invitation, as always.